Today, we are going to discuss an important occupational lung disease called byssinosis, also known as cotton dust lung disease. In this clinical case discussion, we will analyze the patient step by step, following the structured case sheet format, starting from patient details, presenting complaints, past medical history, examination findings, pathophysiology, investigations, and finally management. Let us begin with the patient details. This patient is a 45-year-old male who works as a cotton mill worker, specifically a spinner. His job involves constant exposure to cotton fibers and dust particles in the textile industry. Occupational exposure is extremely important in respiratory diseases because many lung conditions develop slowly due to long-term inhalation of harmful particles. In occupational medicine, identifying the patient's profession can sometimes be the most crucial diagnostic clue. In this case, the occupation immediately raises suspicion for diseases related to cotton dust exposure, including byssinosis. Now let us move to the presenting complaints. The patient reports chest tightness that is worse on Mondays, along with shortness of breath, chronic cough, and wheezing during exertion. One of the most characteristic symptoms of byssinosis is the so-called Monday chest tightness. This occurs because workers are exposed to cotton dust again after a weekend break, which triggers an inflammatory response in the airways. After repeated exposure through the week, the symptoms may temporarily improve due to adaptation, but the long-term damage continues to accumulate. The patient also reports dyspnea, which means difficulty in breathing. This occurs due to narrowing of the airways and increased airway resistance. Additionally, the patient has a chronic cough, which is a common protective reflex attempting to clear inhaled irritants from the respiratory tract. Another important symptom described here is monophonic wheezing. Wheezing occurs when air flows through narrowed airways. A monophonic wheeze suggests obstruction in a relatively large airway segment rather than diffuse small airway involvement. Now let us examine the past medical history, which provides further diagnostic clues. The patient has more than 10 years of employment in the textile industry. Long-term occupational exposure is essential for the development of byssinosis because the disease develops gradually due to chronic irritation of the airways. He also reports recurrent episodes of Monday chest tightness, which further strengthens the suspicion of this occupational disease. Another important point mentioned is previous exposure to cotton dust during carding and spinning processes. These processes release large amounts of airborne fibers and microbial contaminants that can trigger airway inflammation. The patient is also a cigarette smoker. Smoking is an important confounding factor because it can worsen airway inflammation and accelerate lung function decline. In clinical practice, smoking history must always be evaluated when diagnosing occupational lung diseases. Now let us move to the general examination findings. The patient's vital signs are mostly stable, although there may be mild tachypnea, which means slightly increased breathing rate. This occurs because the patient must work harder to maintain adequate oxygenation due to airway obstruction. The patient has a persistent cough, often described as a hacking cough. This type of cough is common in chronic airway irritation. On auscultation of the chest, monophonic wheezing is heard, especially during episodes of Monday chest tightness. In advanced cases, patients may develop decreased breath sounds because airflow through narrowed bronchi becomes limited. Another feature sometimes seen in chronic lung disease is a barrel-shaped chest, which indicates long-standing air trapping and hyperinflation of the lungs. Now let us examine the systemic examination findings, focusing on the airway changes. In a normal alveolus and bronchiole, the airway lumen is open and air flows smoothly into the alveoli where gas exchange occurs. However, in byssinosis, the bronchioles become inflamed and constricted. Cotton dust particles trigger inflammatory reactions in the airway lining. As a result, the bronchioles narrow and mucus plugs may form inside the airway lumen. This narrowing increases resistance to airflow, especially during exhalation. The trapped air leads to hyperinflation of the lungs over time. Radiologically, a chest X-ray may show subtle hyperinflation, particularly in advanced disease. However, in early stages the chest X-ray may appear normal, which means imaging alone cannot confirm the diagnosis. Now let us explore the pathophysiology of byssinosis, which explains how the disease develops. The process begins with inhalation of cotton dust particles during textile work. These dust particles often contain bacterial endotoxins and plant materials. Once inhaled, they stimulate mast cells in the airway mucosa, leading to the release of inflammatory mediators such as histamine. Histamine causes bronchoconstriction, meaning the airway smooth muscles contract and narrow the bronchial lumen. At the same time, inflammatory cells infiltrate the airway walls, causing airway inflammation and edema. This combination of bronchoconstriction and inflammation results in increased airway resistance, which leads to airflow limitation. Over time, repeated exposure causes chronic airway remodeling and persistent obstructive lung disease. Clinically, the disease progresses through several stages. In grade I byssinosis, the patient experiences Monday symptoms only, which usually resolve during the rest of the week. In grade II, the symptoms begin to appear on multiple days of the week. In grade III, the symptoms become persistent and severe, leading to chronic respiratory disability. Now let us move to the investigations that help confirm the diagnosis. The most important test is the pulmonary function test, or PFT. In byssinosis, pulmonary function testing typically shows a significant drop in Phe-Vone, particularly after returning to work on Monday. Phe-Vone refers to forced expiratory volume in 1 second, which measures how much air a person can forcefully exhale in the first second of breathing out. A reduction in Phe-Vone indicates airflow obstruction, which is characteristic of diseases such as asthma, COPD, and occupational airway disorders like byssinosis. Chest X-ray is another investigation often performed. In many cases, the chest X-ray appears normal in early disease. However, advanced disease may show lung hyperinflation, which reflects air trapping due to obstructed airways. High-resolution CT scan, or HRCT, provides more detailed imaging of the lungs. HRCT may reveal ground glass opacities or small nodules, although these findings are usually nonspecific. Another test sometimes performed is sputum analysis, mainly to rule out infectious causes such as tuberculosis or bacterial pneumonia. In occupational lung diseases, it is also important to monitor serial Phe-Vone values over time. A progressive decline in lung function strongly supports chronic airway injury due to workplace exposure. Finally, let us discuss the management of byssinosis. The most important step in treatment is exposure avoidance. The patient should reduce or eliminate exposure to cotton dust. This may involve improving workplace ventilation, wearing protective masks, or even changing job roles within the factory. Next comes drug therapy, which mainly focuses on relieving airway obstruction. Short-acting bronchodilators, such as albuterol inhalers, are commonly used to relieve acute bronchoconstriction. For patients with persistent symptoms, long-acting bronchodilators may also be prescribed. Another important supportive measure is smoking cessation, since smoking significantly worsens lung inflammation and accelerates disease progression. In advanced cases, patients may benefit from pulmonary rehabilitation programs, which include breathing exercises, physical conditioning, and education on respiratory health. If severe respiratory impairment develops, oxygen therapy may be required. Long-term follow-up is also essential. Patients should undergo regular lung function monitoring and periodic imaging to evaluate disease progression. In summary, byssinosis is an occupational obstructive lung disease caused by chronic inhalation of cotton dust. The hallmark clinical feature is Monday chest tightness, especially in textile workers. Diagnosis is based on occupational history, symptoms, pulmonary function tests, and supportive imaging findings. Early detection and removal from exposure are the most effective ways to prevent permanent lung damage. Understanding occupational lung diseases is extremely important because many cases can be prevented with proper workplace safety measures and early intervention.